Let's Talk About Pain, a podcast from the Quebec Pain Research Network. In each episode, we discuss the latest advances in pain research with guests from across Quebec in the health and research communities. Enjoy your listening.
Hello. This episode was originally produced by Carmen Edith Pillai Riddell, a psychoeducator with a PhD in health science research who is now undergoing her second postdoctoral fellowship with Dr. Luana Coloca at the University of Maryland. Her research interests include pediatric pain, the placebo and nocebo effects, as well as ADHD, attention, and inhibition. But the episode's animation is provided by me, Don Daniel Okai, a PhD graduate from McGill University from Montreal and now a postdoctoral fellow at the Boston Children's Hospital. For this episode, we're going to discuss about pediatric pain. Let's start with an overview of the subject. Why should we care? Firstly, because chronic pain in children is much more common than we think. In Canada, approximately 1 child in 5 suffers from chronic pain. Some of the most common examples are recurrent headaches, abdominal pain, backache, and arthritis. Yes, you heard well. Arthritis is unfortunately much more common in children than you might think. Pain in children is often not taken seriously. A hypothesis is that acute pain, that is, pain of short duration, is quite common in developing children. Kids fall, scrape their knee, hit their elbow. Most kids go through these things. However, unfortunately, between 1/3 and 1/2 of children with chronic pain seem to maintain pain problems into adulthood. And this acute pain, should we not take it seriously then? Like they say, what doesn't kill us make us stronger, right? Well, it's not quite true. At least, not for everyone. In the medical community, we've also have a tendency to minimize pain in babies and children, to the point where it was common to perform painful medical procedures on them without using any anesthesia whatsoever, even surgery. Imagine for a moment, would you like to undergo this without anesthesia? Maybe you've had this kind of experience without even knowing it. If that's the case, you can't remember it with your memory, but your body may. Untreated, intense, painful experiences can leave physiological scars. On the contrary to making you stronger, people who have gone through this type of experience are more likely to have chronic pain problems later on. So it's important to look at acute or short-term pain in children. During the World Congress of Pain, Dr. Rebecca Pillai Riddell from York University in Toronto gave an interesting presentation on early pain and attachment. First of all, what is attachment? It's something that develops in the first few years of life. We all have different attachment styles, depending on our early relationships with our parents. We can have a secure or insecure attachment. Ideally, parents should respond quickly and appropriately to their baby's needs. A child with a secure attachment is likely to be better at regulating distress. In general, these children have a good balance between exploration and risk-taking versus their ability to protect and regulate themselves. Dr. Pillai Riddell is particularly interested in the relationship between attachment and pain in children who undergo painful medical procedures, such as routine vaccine injections we receive as children. In studying this, she followed thousands of families throughout childhood, from the birth of their babies and onwards. She found that yes, children with more secure attachments had better regulations after a shot and also seemed to be in less pain and were more easily consoled. But, in addition, she found that in younger babies, the mother's attitude during the painful procedure was associated with the attachment style the child would later develop. So, just during the time of the medical procedure, she could already observe attitudes more or less adapted to the child, which could potentially be generalized in other contexts by the mother. It is important to note that in this study, mothers were more often the caregiver that showed up, but the fathers are not excluded from these conclusions. This underlines the importance of supporting parents in the context of painful interventions and of targeting attitudes that enable the child to develop a better attachment. Next, Dr. Pillai Riddell asked herself what are the best practices for supporting and educating parents and clinicians alike about managing children's pain. To do this, we can first ask ourselves what is most important, helping the person develop what to do to better support the child, or what not to do to avoid harm when a child has to undergo a painful procedure. Our reflex is to say what to do to equip people to improve their strategies. But Dr. Pillai Riddell realized that in this context, it's way more important to share what not to do. The reason is simple. Even if we use behaviors that reassure the child as recommended, if we still use behaviors that exacerbate distress, which is not recommended, it doesn't counterbalance. So if I do both, the behaviors I shall not do represent much more weight in the balance than the ones that I do and that are recommended. And what are these precious recommendations? For interventions in the context of pain by parents or clinicians, reducing the child's fear and distress before the painful procedure has a very important impact. When leading studies with adults, adjusting expectations to reduce fear before pain not only reduced their perception of pain afterwards, but it also reduced their physiological response, which is the reaction to pain in their brain. For children, even if you put a lot of effort into reducing distress afterwards, it does not work as well as reducing distress before the medical procedure. Distress and expectations about pain before a shot predict distress and pain after the shot. It's like a domino effect. If you don't intervene before, it's much harder to intervene effectively afterwards, even with lots of effort. A final point to keep in mind in this context is the assessment of the child's pain by parents and clinicians. There is almost always a tendency to underestimate children's pain. Their pain depends on many factors, including age, gender, parental stress, and past experience of pain. It's not an objective experience, and we often don't consider the distress it causes. And the more pain a child experiences during a painful procedure, the more likely he or she is to experience pain in future procedures, and the more likely it is to get worse over time. So a couple of take-home messages. Attachment relationships and pain management are inter-influential. They're pretty much connected. It's important to focus on behaviors to avoid when accompanying a child through a painful procedure before adding positive behaviors. Otherwise, there's no point. It's important to start the intervention before the pain procedure. And be careful not to underestimate children's pain. Their experience is not our own, and this has an important impact on their future pain. So Carmen also had the opportunity to conduct an interview with me during the World Pain Congress of 2022. I was able to attend a pre-conference symposium on pediatric pain. What stood out for me the most during this session was the implication of patient partners, particularly pediatric patient partners in research. Dr. Katie Burney is a psychologist and assistant professor at the University of Calgary. And she invited 3 patient partners, a mother whose daughter has chronic pain, and 2 patient partners who have had pain since they were teenagers. One of the questions Dr. Burney asked was, what can we, as researchers, do better in engaging patients in research? The take-home message was that we should not forget that our patient partners are human. Ask them, how was their day? We should also open our minds to who can be a patient partner and the number of partners in a project. Young patient partners also have great ideas that could help in research. Also, having an open discussion that is transparent with our patient partners is important. Another standout from this pre-conference event was on how to work with children experiencing pain. For this, we should be using a multimodal approach. There are multiple tools, such as medication, integrative therapies such as techniques on the body and mind, rehabilitation, psychological treatments, family support, and much more. Also, the way we talk about pain and collaborate with the patient is very important. Overall, from this event, there's lots of research going on in pediatric pain, and this gives a lot of hope. For the young people out there living with chronic pain, don't hesitate to get involved in research projects as a patient partner because your voices matter and help us in research. Carmen also had a nice chat with Dr. Gabrielle Pagé, a psychologist and researcher at the University of Montreal. She doesn't work on pain in children, but on stress and anxiety associated with pain. It's a very important subject to address because pain and anxiety are often comorbid, which means present at the same time. Dr. Pagé gave a talk on the link between stress and pain, but particularly paying attention more on how pain can be a source of stress for people and how it can have an impact on their mental health, which then has an impact on the way that they perceive pain. Pretty much like a cycle. This comes from research highlighting that pain is variable throughout the day and is not static. Moreover, these fluctuations cannot always be predictable, which can be stressful. Dr. Pagé says that this is a hot topic within the pain research field. If we ignore variability of pain, the variability of healthcare usage, or the variability in treatment response, we are missing pieces of the full picture. In Carmen and Gabrielle's conversation, they discussed that to treat stress, we need to understand the model CINE, C-I-N-E, which was developed by Sonia Lupien, the founder and scientific director of the Center for Studies on Human Stress. When we are in stress, when our bodies are releasing cortisol, it is because we are facing something that we cannot control, for the letter C. That's also unpredictable, which represents the letter I in the French acronym, something that is new, for the letter N, and something that menaces our ego, for the letter E. Dr. Pagé mentions how we can look at the same model for pain, thinking of it as a stressful event. For example, can we do anything to take back control in that moment? This would help decrease the stress of that particular moment of spontaneous pain. Their discussion ends with sharing multiple resources on how to handle stress and pain, which will be linked to the description of this episode. Well, this concludes the episode on the specific theme of pediatric pain, and I hope you enjoyed it. I invite you to check out the resources in the description as well and share them with anyone who might benefit from them. Until next time, thank you.
Thank you for listening to Let's Talk About Pain. Don't hesitate to subscribe so you don't miss an episode and to share the podcast with your friends. For more information, visit our website at qprn.ca or our YouTube channel by searching Quebec Pain Research Network. See you next time.